pleasure to be here at Franklin and Marshall College. Thank you, Ethan, for that kind introduction and for inviting me. So we're going to talk today about transgender medicine. And I have learning objectives to make it academic. So we're going to talk about gender identity and sexual orientation, talk a little about health disparities, and then some specifics about transgender medicine. So if I said LGBT, I think that almost everyone in the audience would know what I mean. But if I said LGBTQIAAP, how many people know what I mean? Not so many. So we're going to go through that. So we're all talking in the same language and understand the same terms. So LGBT is lesbian, gay, bisexual, and transgender. Other terms, though, one would be Q. The first Q is often questioning. Those who might question their sexual orientation or their gender identity. The second Q is queer. Now, for people my age, of my generation, we often have shuddered when we heard the term queer, because queer was a very negative term, a derogatory term, but the term queer has really been taken over by the LGBT community as an umbrella term. And many, especially young people, really cling to this term and will identify themselves as queer. And so we old people have to kind of get used to that. I would be intersex. Patients who are, individuals who are intersex are those with, medically, we would call a disorder of sexual development or a disorder of sexual differentiation. And that really means actually a chromosomal or other genetic condition or a hormonal condition which renders them intersex. And there are a number of different conditions that do that. A would be asexual or agender. And the last A are allies. And allies are those who are not on the rainbow, so to speak, but support the community. And we are very, very grateful for allies to our community. P can mean pansexual, polysexual, pangender, polygender, and there are lots of other terms, two-spirit, and I could go on, basically spend the entire 45 minutes talking about different alphabet soup. But that gives you a kind of a flavor of the terms that we would use. I want to differentiate three expressions. One is gender roles, the other is sexual orientation, and the third is gender identity, because they're all subtly different. Gender roles would be sort of what role you might have in your family, in your community, in society. And gender roles have changed, obviously, dramatically in the last 50 to 75 years, at least in Western culture. The best example of changing gender roles that I have is my very dear 92-year-old mother. My mother was the only graduating female law student at Boston University in 1946. My mother graduated law school in 1946 when women didn't become lawyers or doctors or didn't go into any professions. And of course, if you look at any professional school now, at least about approximately 50% of the class will be female. So gender roles have changed dramatically in our society. Your sexual orientation is who you are attracted to, who you might want to have a relationship with, who you might want to be intimate with. Your gender identity is how you feel inside, whether that's male or female. We'll talk about some other issues about that in a couple minutes. And they're very different terms. So you might be male identified at birth, but your gender identity is female. So you would be a transgender girl or woman. Or you might be female identified at birth, but identify as male, and you might be a transgender boy or man. If you're not transgender, you're cisgender, right? So if you identify with the gender you were at birth, then you are cisgender. So congratulations to most of the people in the audience, but not all. But you are cisgender. That's how you would be classified. There is no particular overlap between sexual orientation and gender identity. So you might have someone who is a transgender girl or woman who is attracted to men, or women, or both, or neither. And you might have someone who is a transgender man who is attracted to men, or women, or both, or neither. So you do not know someone's sexual orientation by knowing their gender identity, or their gender identity by knowing their sexual orientation. They are two separate concepts. So a general theme of this talk when you meet transgender individuals is don't make any assumptions, because almost always your assumptions are wrong. So sex is this physical expression of the genes. We've been talking about gender, this self-perception about how one relates to society, traditionally male or female, although we'll talk about some other ideas about that later. And a hypothesis that I would give you is the organic basis of gender identity is a reflection of neurodevelopment of the brain, that it's biological, as opposed to a competing hypothesis that it is somehow psychological or developmental, that it's somehow your mother dropped you on your head when you were 6 months or something like that. To be fair, there are competing ideas, although this is the prevalent theory, but it is a theory, and so I have to prove this to you. So let me talk about some research studies. So the first studies on this, we're looking at people who are transgender or transsexual and looking at their brains. And so these earlier studies in the 90s and early 2000s looked at the brains of people who were transsexual, and they looked at neuron numbers, so the shape or size of different cells in their brain. And these two studies showed that male to female transsexuals had female neuron numbers of this nucleus. And there were two studies, like a number of different studies. This was a bigger one, looking at the hypothalamic uncinate nucleus in people who were transgender. And again, if you were male to female transgender, the nucleus looked kind of female, and if you were female to male, it looked kind of male. And this was actually quite a big study. There were two problems with these studies. The first is, these are cadaver studies. It's really hard to look at the neurons themselves on slides in living people. So these were people who were deceased. And so, how many studies are you going to have? I mean, you have to have a lot of dead transgender people who donate their brains to science, There's only so many. So we're limited in terms of the number of different specimens that you're going to be able to see. The second limitation, the second variable of these studies, was that many of these people had been on hormones. So do these changes reflect the action of the hormones, or would they predate the hormones? And you cannot tell from these studies. So the future is structural and functional neuroimaging. You don't have to worry about the specifics, but this one looked at white matter microstructure. And in this study for female to male transsexuals, before hormones, the brains look kind of male. In the companion study in male to female transsexuals, the brains look in between male or female. So the idea was that their brains were consistent in terms of their structure with their gender identity. This study looked at gray matter and also found that. And this study also looked at, there was another study that looked at functional neuroimaging as well. So it really supports the differences in neuroanatomy and function between transgender individuals and cisgender individuals or controls. Now, there's a lot of overlap, however. And so you can't use it for a diagnosis. And it's going to be complex. So it's not going to be one structure or one specific circuit that determines your gender identity. Human behavior is much more complex than that. So it's going to be the interaction of many different structures and many different circuits. And there's a lot of different causes and pathways, so none of that has been delineated. And so again, you can't look at karyotype, which means at your sex hormones. You can't look at hormone levels, and you can't do neuroimaging to make a quote-unquote a diagnosis. Basically, the diagnosis is made by what the individual tells you. And so all of this is kind of a research study. And so, this is an old quote, but gender identity, whether consistent or inconsistent with, for instance, your birth gender, is not a matter of choice. It's a matter of biology. And the prevailing hypothesis, which still needs to be further studied and further proved, is it has to do with the neurodevelopment of your brain, primarily in utero. And now the next question is, well, why would brains develop different than their birth sex? And so all that needs to continue to be studied. But it's not a matter of choice, and you don't wake up one day and decide, gee, I'm bored, I'm going to be transgender. So there is a spectrum of transgender presentation. Okay? And there's male to female, M to F, transgender women, and there's female to male, F to M, and transgender men. It's about 50-50. Previous studies seem to indicate more transgender women, but that's not true. So it's about 50-50. But there is a spectrum in terms of presentation. So you might have someone that's on this end of the spectrum who wants to present as the other gender at times, wants to dress as the other gender at times. They might want to do that every day, or they might do that once a week, or they might do that at a meeting once a month, or at a conference once a year. They might usually want to do that because they feel comfortable. They find presenting as the other gender as fulfilling. And the old term for that was a transvestite. I recommend you not use that term. It's considered kind of a negative pejorative term, but the current term would be someone who cross-dresses. But by definition, someone who is on that end of the spectrum doesn't want to physically and socially transition to the other gender. And then you have someone on this end of the spectrum, often called someone who's transsexual, who wants to physically and socially transition to the other gender from their birth gender. But people don't pigeonhole into categories very well. So if this is one or 2 and this is 9 or 10, what if you're 4.7325, or 6.9726? And people kind of flow among the spectrum. So I know for most people in the world, your gender seems somewhat fixed. It's your birth gender, and you don't question it. You might question many things in your life. You might question your family. You might question your education. You might question your federal government. Please do. Tomorrow, actually. Not today, tomorrow. You might question your school, but not at Franklin and Marshall. But you don't question your gender. It's a fixed star in the universe. But actually, that is not my experience and the experience of many people I know. Gender seems to be actually very fluid and among a spectrum or continuum. Now, that is still assuming a binary of male and female. However, actually, for many young people now, they do not accept that binary of male or female. And so they might use terms such as gender nonconforming, or gender non-binary, or gender expansive, or gender fluid, or gender queer, and I've probably missed some terms. And they do not accept that binary of male or female, and they're going to express themselves in their gender role and their sexuality in any way that they want. And so actually that is the brave new world in terms of gender issues and gender studies. And actually the medical field has yet to catch up with that. You will find that more in college campuses than you will at the state capitol. But it is actually the brave new world in terms of how gender is expanding in our world. Being transgender is a DSM diagnosis. How many people know what the DSM is? Oh, wow. So the DSM is the Diagnostic and Statistical Manual of Mental Disorders. Say that 3 times real fast. And it is basically this large tome that talks about, that defines psychiatric disorders. We're on DSM-5 now. The previous one was DSM-4. Lovely bedside reading. You put that next to your bed and you fall asleep. It is the most powerful sleep aid known to man. You don't need little pills and butterfly pills and stuff like that. And so the term went from gender identity disorder, with the idea that it was a disorder, to gender dysphoria, and taking the disorder out, because not being transgender by itself is not a mental health disorder. Personally, I think that for the young people in the room who might be psychology majors and going into psychology or psychiatry, when you're writing DSM-6, being transgender will be taken out of the DSM. Now, you might have gender dysphoria with impairment, but if you have gender dysphoria, you're transgender, you need to transition, and you're not impaired, why is that a psychiatric diagnosis? So I'll just put out that question for you. Thank you. So, but I think that's going to be you all who write the DSM-6 that takes it out. You have to remember that until the mid-1970s, being gay or lesbian was a mental disorder. It was only taken out 40-so years ago. Now, what is the paradigm of patients that would come see me at Penn State Hershey when I was seeing patients with transgender medicine? I've been this way as long as I can remember. At age 5 or 6, I wanted to be a girl or a boy, or I'd go to bed at night and pray that God would change me, or I'd wake up and darn, it's still there, or it was not there. And this little boy was great. He said, puberty was awful. My body changed from what I wanted. I grew hair and tentacles. And I went, Johnny, you grew tentacles. You mean testicles? And he went, oh yeah, testicles. I was like, I'm glad he didn't grow tentacles. I mean, that that would be like a pediatric surgery consult or something. I don't know. But he grew hair and testicles, and it was very disturbing. We'll talk about puberty in a minute. So this would be a patient that I had been commonly seeing at Penn State Hershey. 19 years old, M to F means male to female, referred by her college health service for evaluation, been seeing a therapist, felt female since her earliest memories, somewhat depressed about all of this and coping with it and the discrimination that she was feeling. She was attracted to girls, and she had females, and she had a girlfriend. And so she was evaluated. She was treated with hormone replacement therapy. She developed female secondary sexual characteristics very nicely. She did well in school, and she had gender confirmation surgery and went on to graduate school and lived her life. So the standards of care for transgender medicine are established by the World Professional Association for Transgender Health, or WPATH. And that's the website, wpath.org, easily available website. And the last revision was 2011, and there is a new revision hopefully this year. It's supposed to be last year, but hopefully this year. And hopefully with the medical guidelines, they'll take under consideration gender expansive individuals much more, because the guidelines are actually pretty gender binary. And it talks about the evaluation and treatment of individuals who, on the spectrum I was talking about, were transsexual. Because you can think about it, if you're on this end of the spectrum and you cross-dress, almost by definition, you're not seeking medical treatment. That's kind of how it's defined. So if you cross-dress, then that's great, cross-dress, and I hope you're happy and fulfilled, and that's great, but you don't need me. You don't need a physician. So only if you're seeking hormones would you sort of meet these criteria. It still does recommend a psychological evaluation. That's kind of controversial if you want other types of hormone treatment. If you need hormone treatment for menopause, you don't need to have a psychological evaluation. If you are a man in their 40s, 50s, or 60s and you need testosterone or Viagra, they don't recommend a psychological evaluation. Maybe they should, but they don't. And if you want a nose job, you don't need a psychological evaluation. But if you want gender confirmation surgery, you do. So I'm very in favor of psychologists and mental health and psychological evaluations to require it. You could argue, but that's required. And then there's hormonal therapy and surgical therapy, and we will talk about all these things. So who is eligible? Well, it's useful to know what hormones will do and what they won't do. Some people have inappropriate expectations of what hormones will do. Again, a mental health evaluation is required, psychotherapy recommended. I'm very in favor of continuing counseling as someone receives hormones for gender transition or surgery. Changing your gender is actually not as easy as you might think, and it rocks your world, and it rocks everybody else's world. So I think seeing a therapist is very useful. It is necessary to live as the other gender before you have gender confirmation surgery. Again, other gender means binary, so as we move into more of a non-binary schema, what that means is not so clear, and we'll talk about AIDS considerations. So why would you give cross-gender hormones to an individual? Cross-gender hormones have been shown in study after study to play an important role in the physical and psychological transition. They're medically necessary to live as the other gender and your new gender, and they've been shown over and over again to improve the quality of life and to limit psychological morbidity, which accompanies lack of treatment. So from a medical point of view, there are male to female regimens and female to male regimens. For male to female regimens, you're going to use an anti-androgen. You have to give a medicine to block the production and action of testosterone. For anyone medical in the room, the medication we usually use is called spironolactone. It's an inexpensive medicine. And then you're going to give estrogens to feminize the body. And there are a number of different estrogen compounds you can use. Essentially, for an adult individual, who's being treated, they're going to go through the other puberty. Okay, so if you are a transgender woman, such as myself, you're going to go through a female puberty, transgender man through a male puberty. Puberty takes 3 or more years, right? 16-year-old boys and girls look different than 12 and 13-year-old boys and girls. And so there's no way to do this faster. People are impatient and they want everything to happen yesterday, but it takes time to go through the gender transition process physically, which is probably a good thing, but it takes time. For female to male individuals, you're going to use androgens. So essentially that's testosterone. And there are topical preparations, but there's no oral preparation. And the preparation that's primarily used is intramuscular. It's a shot. It's figuratively and literally a pain in the butt every 2 weeks, a shot in the butt every 2 weeks forever. So it is a shot which will masculinize the body, and the person will go through a male puberty. The benefits I've mentioned in terms of living as the other gender, both physical and psychological benefits. There are side effects that a physician needs to monitor. So I am not in favor of getting your hormones online. I am not in favor of getting hormones on the street. If you use street needles, it puts you at risk for hepatitis and HIV. But online, you never know what you're getting. You really need to see a physician or a nurse practitioner or a physician's assistant, but a medical provider to monitor blood tests and to monitor for any potential side effects. Both sets of hormone regimens can increase your risk of a blood clot, so we really want people not to smoke cigarettes. This is the article from 2009, which kind of outlines the protocol of assessing someone, what blood tests to do, what hormone, what doses of hormones, how to increase the doses, etc. So this would be sort of the medical standard of care that we follow. But for patients that I saw and the parents of young people that I saw, what I really tried to emphasize is that this is a medical field now. And we're not winging it, We're not making it up as we go along. This is an established medical field. There's an international organization. There's a standard of care. There's a journal. There's research articles. And so this is an established field. Transgender medicine is an established medical field now. And we need to do a better job teaching students as well as practicing healthcare providers about this. So what if you're a transgender teenager, right? So what if you remember puberty? Wasn't that fun? Wasn't that a lot of fun? So what if you're going through the wrong puberty? What if you're a transgender young woman, meaning male to female, and now you're getting, your voice is dropping, you're getting bigger, you're getting hair everywhere, and you're growing those tentacles, And what if you're a transgender young man and now you have breast development in periods? It can be terrifying, and there's a lot of mental health issues during that time. So here's 2 examples. So 17-year-old young man that I saw in clinic, referred by his pediatrician, always identified as male, again, female identified at birth. Parents in school were supportive. He had not seen a therapist, sent him to a therapist, and we treated him. He was given intramuscular testosterone. He is now in his 20s, and he's doing great. 16-year-old young transgender woman, male to female, always felt female. You can get the theme here. Wanted to start hormones, lived with her mother who was supportive, saw a therapist who was supportive. She was given spironolactone and estrogen and transitioned, and now is in graduate school in her early 20s and did absolutely fantastic. So some patients that I would see. So the previous treatment before these new guidelines came about that's when you're 18 and have a nice life. Basically, there was no medical treatment for individuals that were under 18. So there are new guidelines, and so these are the new guidelines that are very well accepted by healthcare professionals. They're international guidelines, and most children's hospitals will be doing this. I did this. I would treat patients at Penn State Hershey Medical Center when I was there. I think they're trying to find someone to do that. Probably the biggest program near here is at Children's Hospital of Philadelphia in the Penn system, and they have an excellent clinic for transgender youth. So for prepubertal children, there is no medical treatment. Well, that kind of makes sense. I mean, they're prepubertal, so they don't really have clinical levels of sex hormones, so what medical treatment would you want to do? So the idea would be to see a counselor or a therapist who is supportive, who has knowledge about these issues, to, come, you could some see me medically, and then depending on their age, come see me in a year or 2, but there's nothing medical to do. Work with the parents. For the parents of transgender youth, it can be very, very challenging. You know, the transgender individual is being very affirmed by getting treatment and being accepted as the gender to which they identify. To the parents, whether the young person is 6 or 15 or 52, it feels it's a loss. It feels like a death. You are losing the son or daughter that you thought now you're gaining a son or daughter, but it's still, you still actually almost grieve the child that you thought you had. And I know for the transgender individuals it doesn't make any sense because I'm still here, but that's the way it feels to parents. And so we have to do a lot of counseling with youth about letting their parents go through this process because there's no way to make that faster. And sometimes, I mean, the youth is ready to go, and you have to help the parents come along. And otherwise things don't go well. So the parents, for youth, the parents' feelings are critically important to have things go smoothly. But for prepubertal children, they might present in different ways. They might present at school in the gender they were identified were at birth, or they might present as the other gender, or they might be more gender fluid. But you kind of let the child kind of with counseling and with the family kind of determine how they present, but there's no medical treatment. So at the start of puberty, so if they fulfill all the criteria with pubertal stage 2, which means you're just starting puberty, and everyone's on board. So the parents are on board, the therapist is on board, the physician's on board, and obviously the patient's on board. Then you can do this protocol. So the protocol, was developed in the Netherlands, has 2 phases. The first phase, at the young adolescent age, is to give what are called a pubertal blocker, to give a medicine to block the progression of puberty so you don't go through the wrong puberty. And then to continue some counseling. And then somewhere between 14 and 16 years of age to start slowly cross-gender hormones. Again, they have to go through puberty. Puberty doesn't happen, it's going to take years. So you start low doses, you gradually increase, so that they never go through the wrong puberty. That way, for a transgender woman, male to female, their voice doesn't drop, they don't have hair, they don't have to have electrolysis. For a transgender man, they don't have breast development that will need surgery, they don't have periods, etc. So you block puberty, and then you can, at the appropriate time, send them through the puberty consistent with their gender identity. Does that make sense? Okay. So it's two phases. And then there are follow-up protocols. Most surgical treatment would be done at around 18. There are some procedures that might be done earlier than 18, and there are some exceptions. Now, this is a great protocol if you're seeing patients in the cornfields of Hershey, or at the Children's Hospital of Philadelphia, where the parents bring them and they all have nice insurance and this and that. If you are, however, at the Mazzoni Center, which is the LGBT center in inner city Philly, and you're seeing street youth who have been essentially thrown out by their parents because of their gender identity and expression, you don't always have the luxury of all of these protocols, so you don't usually use blockers. If you don't give them hormones, they're going to get street hormones, which puts them at risk for infectious diseases. So you might accelerate this if you're seeing street kids. So the academic protocol I just shared with you, but in practice, if you're seeing street youth, whether it's Philly or New York or LA or Boston or Washington, then you might have to accelerate this somewhat so that the young people feel validated and are getting care consistent with their pace and their path, so they don't go to the street. Does that make sense too? So surgery. I'm not a surgeon, so I'm not going to talk too much about surgery. It used to be called sexual reassignment surgery, but the term right now is usually gender confirmation surgery. There are male to female regimens. There are female to male regimens. There are genital surgery regimens. There's breast surgery regimens. So if someone who didn't get the blockers, who is male identified and has large breasts, will probably want a double mastectomy and creation of a male chest. It's very hard to be a male-identified person with large breasts. If you have someone who is male to female identified, a transgender woman, they might want more breast development. Now, the hormones will do that very nicely, but smaller than cisgender women. I usually tell people to be happy and to be patient. They'll come in and say that their breasts, they don't like their breasts, and they think that they don't like the shape, and they're asymmetrical, and they want breast surgery. And I said, in my practice, I took care of a lot of genetic women, they didn't like their breasts either. They wanted them different or bigger, or they were asymmetrical. So, welcome to the female condition. But some people, some cisgender women want surgery on their breasts, and some transgender women want surgery on their breasts. There's facial feminization surgery. Men's and women's faces are different. So hormones don't change your bones, right? So if you are, 5'9" and weigh 175 pounds, then you'll be 5'9" and weigh 175 pounds. If anything, with estrogen, you might gain weight. But if you are, 6'2" or 6'3" and have size 14 shoes and you weigh, that's your body structure. It doesn't change your bones. It'll change your body habitus significantly, but your bones are your bones. So that can make it challenging for some people. The only thing is, don't assume that everyone wants surgery. Not everybody wants surgery. Now, one of the reasons is insurance didn't cover it, so we'll talk about that in a second. But not everybody wants to have surgery. Some people are very happy with their genitals. They're just even though they have penis and testicles, but they're female identified. And so don't assume that everybody wants surgery. You need to ask that if you're, in the treatment field. Transgender individuals face particular disparities. So there was an excellent survey, and you should look this up. This is from the National Center for Transgender Equality, and they had a survey with thousands and thousands of individuals. And they looked at their experiences with healthcare and other experiences. A third, this is 2015, this came out in December. It was analyzed and came out this year. A third of individuals experienced a negative reaction from a healthcare provider, meaning that they came out as transgender and their healthcare provider was very negative about that. 40% of transgender individuals have attempted suicide in their lifetime. 40%. That's not suicidal thoughts, that's attempted suicide. And that's compared to the general population, which is between 4 and 5%. HIV risk is much higher. And now, with regressive laws such as House Bill 2 in North Carolina, in terms of restroom access, we have transgender individuals who won't go to the bathroom in school for the entire day and end up with urinary tract infections because they will not go to the bathroom in the restroom for the gender that they don't identify with. And lots of healthcare disparities, and it's the social determinants of health that are related to depression and discrimination. So in terms of mental health issues, in terms of substance abuse issues, which can be increased in transgender individuals, LGBT individuals in general, it's nothing about being LGBT. It's nothing about being on the rainbow, which predisposes you to mental health issues. It's the discrimination, the harassment, and the discrimination that individuals face that leads to some of these negative mental health outcomes. Legal discrimination in terms of health insurance access, employment, housing, retirement benefits, lack of laws protecting against schools, and lack of social programs for LGBT youth and adults. Nearly a quarter of the respondents to this survey had housing discrimination, meaning that they were evicted from their home or their apartment because they were transgender. And more than half of those who seek treatment, as I was describing, were denied by their insurance company. And we're going to talk about Pennsylvania in a second. So one of the things that's important to know, and I wonder how many of you know this, there is no comprehensive non-discrimination law in Pennsylvania that includes sexual orientation or gender identity and expression. How many people knew that? So a transgender individual or LGBT individual in Pennsylvania could get fired from their job because they're LGBT. So I transitioned at the Penn State Hershey Medical Center, Penn State College of Medicine, and actually, they had a non-discrimination clause which included sexual orientation. It did not include gender identity and expression, so we developed that with the diversity office, called the Levine policy, and I was, not just tolerated or accepted, I was welcomed for the diversity I brought to the medical center. But if I had worked for a practice down the street, they could have said, you're transgender, you're fired. That would be legal in Pennsylvania. That's legal. You can get married with marriage equality to your same-sex partner, and in most places in Pennsylvania, declare that you're now married and proudly put your wedding picture on your desk and be immediately fired. I could go to buy a house in most places in Pennsylvania, and they'd say, I know you. You're the transgender physician general. I keep waiting to meet the cisgender physician general because I'm the transgender physician general. You'd think that there'd be two, but haven't met him or her yet. But I could say, oh, I'm not gonna sell you a house. That's legal in most places in Pennsylvania, unless there's a municipal statute. 35% of LGBT individuals feel compelled to lie at work because of those issues. So 90% of people who are transgender report harassment and mistreatment, lost jobs, etc. So Governor Wolf and the administration are very supportive of our community. They are very supportive of the LGBT community. The governor did sign 2 executive orders that expanded protection in terms of jobs for those who are employed in the administration and for companies that do business with the administration. Have to have comprehensive non-discrimination that includes gender identity and expression and sexual orientation. We have an LGBT work group through the governor's policy office, and I am very pleased to co-chair that. And so we have all the agencies involved. You can see all the different alphabet soup agencies: Department of Health, Department of Human Services, Corrections, Education, Commerce, etc. Pennsylvania State Police, Military and Veterans Affairs. And so we meet monthly to work on, it's a work group, so we're not just kind of talking about things. We are working on increasing LGBT protections and programs in Pennsylvania through Governor Wolf's administration. We work with several of partners in the community, including Equality Pennsylvania, statewide advocacy group, Trans Central Pennsylvania. There is a transgender support group in Central Pennsylvania, in Harrisburg, and the Pennsylvania Youth Congress for youth, high school and college youth who are on the LGBT spectrum. We have upgraded the operational policy for transgender individuals. You no longer have to have any type of surgery to change your gender on your birth certificate in Pennsylvania. We changed that last year. Starting now in 2017, for parents on their birth certificate of your child, it'll say parent, parent, and not mother, father, starting this year in 2017. Medicaid in Pennsylvania now covers gender confirmation treatment, including psychological evaluation and treatment, medical evaluation and treatment, and surgical evaluation and treatment. And we are working with the Department of Insurance on expanding that with private insurance as well. We are working with the Department of Education on the Title IX guidance that was put forth through the Obama administration for support of transgender individuals in schools. We have worked with the Department of Corrections on their PREA policy, which is so to prevent risk of sexual harassment and rape. In terms of transgender individuals in corrections, very challenging. We're working on with the Office of Administration for a written policy for LGBTQ employees of the Commonwealth. So we're working on all of these issues. Now, challenges for the future. Access for treatment. So Pennsylvania Medicaid covers transgender treatment, and there is a lot of resources in Philly, and there's a lot of resources in Pittsburgh. There is the Alder Health Clinic, which is in Harrisburg, and they have a branch here in Lancaster, and you can access treatment here in Lancaster. But if you're in most of Pennsylvania, it's very hard to access gender confirmation treatment, so we're working on that. There have been 3 surgeons in Pennsylvania that do gender confirmation surgery. We have worked with one who now works at Hanuman Hospital who will accept Medicaid. So we're really working for access to qualified health professionals, but we need to work on training programs for psychologists as well as medical professionals and surgical professionals so that we can improve access to the services that hopefully are now covered. And again, we need newer treatment guidelines for gender non-binary individuals. The last word is that, tomorrow there is an inauguration and we have a new president and new administration. And so what will be the future from the federal government? And we don't know that yet. So, and we'll wait and see. I am an optimistic person, and so I will be cautiously optimistic that we'll be able to protect and maybe even expand programs for LGBT individuals and transgender individuals. There might be some challenges with the new administration. Certainly the Obama administration has been extremely supportive from the federal government point of view. But I can reassure you that Governor Wolf and our administration are very completely supportive for LGBT individuals and programs and transgender individuals. And in a minute, I'm going to ask for questions. So the only thing I want you to do is I want a favor. So this year, in 2017, I'm going to have an interesting birthday. Right? It's going to be very interesting. So I want a birthday present. This will be the 30th anniversary of my 30th birthday. So I would like you to follow me on Twitter. So that's my Twitter handle, @PhysGenLevine. We'll, of course, be tweeting about the program today, so please follow me on Twitter. Thank you.
Hi, thank you so much. I'm Carol, and I'm a senior citizen, but I work here. Okay, so I have a question, because I'm currently being treated for a hormone-driven breast cancer, and all the hormones are being sucked out of my body for this.
Yes.
So does all these hormones being put into these transgender individuals' bodies, I mean, are they finding that they cause cancers, or are they studying this later on? Can you get breast cancer if you're a transgender? I mean, all that,
Sure.
What is all this doing to the
It's a
body?
very good question. So there is no evidence. So it is intensely being studied, and there is no evidence of cancer from the hormones. Now, if we know that someone has for instance, an estrogen-dependent cancer, then we would not prescribe estrogen. So for a transgender woman who otherwise would get estrogen, we wouldn't prescribe that. There are a few patients, my field is adolescent medicine, adolescent and young adult medicine. But because both for eating disorders as well as for transgender medicine in central Pennsylvania, there was no one else besides me to do that treatment. What was interesting is adolescent medicine meant anybody younger than me. And now you know how old I am. So I saw adults in their 40s and 50s in the past, and we had some patients that couldn't receive hormones. For instance, someone with atrial fibrillation on Coumadin at risk for a stroke. So there are sometimes medical conditions where you can't give hormones, but they're usually very well tolerated. There is no evidence that it causes breast cancer, but it is being monitored and studied. Yes.
Hi, I'm Rachel. I'm a freshman here.
Hi.
What can you do for a patient who doesn't have parental support?
Well, if they're under 18 and they're not an emancipated minor, meaning if they're under 18 and they are on the street or they're completely emancipated from their parents, then you can do treatment. But if you have most, patients under 18, I cannot prescribe hormones without their parents' consent. However, once they become 18, I can. So anybody 18 and older, they give their own medical consent. Now, insurance coverage is another issue. So if the insurance is through your parents, then you're going to have a discussion with them. But I do not need parental consent for anyone 18 or older. Under 17, unless they're completely emancipated, you do. Yeah. Yes.
Hi, I'm Charlie. I'm a junior here, and
Hi.
I'm in the dance anthropology department. I had a question about, do you find any challenges within your work between the intersectionality of the queer community and race and ethnicity? And if you do find challenges there, how do you address them?
I think that issue is becoming more noted and coming more to the forefront as it should. And I think that there have been issues in terms of the LGBTQ or queer community and issues of race and ethnicity. There have been a lot of movement and issues about that in Philadelphia in the last number of months. So I think that it is certainly incumbent upon us in the LGBT community and those who might be in positions of responsibility to be more sensitive to issues of ethnicity and race, etc. I think that issue has not been looked at as intensely as it should have been. Yes.
Hi, my name's Molly. I'm a senior chemistry major. I wanted to start off by saying I really appreciate the things that you said about the parents and their role in the transition, but I was wondering if you could elaborate more on your experience in the full family in the transition, siblings, aunts, uncles, etc.
Sure. It's very difficult. I know that for many young people, the brave new world is a gender non-binary society, but really the society we live in right now is still pretty gender binary. And so I think that it is very challenging for families in general. There are issues for parents, there's issues for siblings, then how you have to deal with the extended family, and then how you're going to deal with school. For transgender adults, there's issues of spouses. In terms of gender transition and what that means for them, tremendous impact on them, children as well. So for children of transgender individuals, I'm going to block on the name of it, but there's a website that has like a virtual support group. I know at Children's Hospital of Philadelphia, they have, and Mazzoni Center, they work together. They have a support group for parents. They have a separate support group for siblings. But there are a lot of things to work through in terms of extended families and for society and schools and things like that. So I think it rocks, again, changing your gender rocks your world, and it rocks everybody else's world that you know. And so I think it's important for transgender individuals just to be sensitive to that and to work with their family as much as they possibly can.
Thank you.
Thanks. Yes?
Hi, I'm Susan Manasian, the college chaplain. I was raised by a mom, believe it or not, in the 60s who became an electrologist and did permanent hair removal to help people in transition. And she would always say that she was helping people become who God created them to be. So it was great growing up in a home that had that value. I know that at like Hershey and other hospitals that they have pastoral care chaplains and people that give care to patients. One of the things I'm curious about, though, when I did CPE, we didn't have anybody talk to us about being a chaplain and dealing with the spiritual aspects of this. And my guess is that a lot of communities of faith are not out there as much in being supported. Do you see any change in that in the hospital setting with chaplains that give attention to the spiritual challenges in this?
I have not. But that might be because I have to admit I'm not sure I reached out to the chaplains. So I think that that's a fantastic idea. So if you are interested in networking with someone, Joanne Carroll, who is the president of Transcendental PA, works a lot with spiritual leaders in terms of spirituality and trans. Yeah.
Okay,
Thank you. Yes.
Good morning. My name is Griffin Sneath. I'm a first year, and as an aspiring surgeon, I just wanted to ask if treatment for transgender individuals is included in surgical and medical residencies, or does that require further training?
It would require further training. So, be honest with you, there has been no training program. There has been no pipeline for surgeons. I mean, there are probably, a dozen surgeons in the country that are expert at transgender surgery. And that's a real problem because, now that more insurance companies will cover it, that's great, but they only have 12 surgeons and they're booked, they're booked for the next 2 years. That's an access problem. So we need to develop new training programs, and it would probably be, you might get some exposure during your residency, but you would really be more of a fellowship after a surgical residency or maybe after a plastic surgery residency. There are a number of different pathways to it where you would get expert training in gender confirmation surgery. The main program I know that is doing that now is Mount Sinai Hospital in New York City. So they are developing a training program for surgeons in this program. Yeah.
Thank you very much.
Sure. Yes.
Hi, good morning. My name is Phoenix. I'm a freshman. So my question is, after a transgender person take this process to trans to another gender, they have to use some hormones to make themselves into another,
Correct.
kind of gender. So is the person have to keep using the hormones?
Yes.
Is there any chance that we could do some surgery stuff kind of things to make the person generates the hormone by itself, not to take doses every time?
I understand. Not at this time. So there's no ovary transplants or testicular transplants. So transgender individual is going to be taking hormones essentially for long-term and foreseeable future. Now, a question has come up about geriatric transgender medicine, right? I mean, is that if someone starts receiving hormones at 45 or 50, they're not going to want to stop them when they turn 60. You can trust me on that. They don't want to stop them when they're 60. However, if we start treating youth at 16 or 18, and then they're in their 50s, wouldn't we put them through, for instance, for the menopause? Maybe. No one's lived that long yet. So who started hormones as an adolescent. So we don't know. So that would be an interesting field in the future is transgender geriatric medicine. But in terms of transplanting any type of glands, any type of there's no evidence of that. So you're taking hormones forever, right?
Thank you.
Or for the foreseeable future. Yes.
Hi, my name is Tom. I'm a junior. I'm a joint American Studies and Government major at F&M. I don't know if you're aware of this, but there's a current pending case before the Supreme Court regarding a transgender student in Virginia that wishes to use the bathroom of their preferred gender identity. And I'm wondering if you could speak to any efforts that your department, the Department of Health,
Sure.
has undertaken with the Pennsylvania Department of Education to ensure that something like that doesn't become an issue in the future here.
So as part of the work group, we have worked with the Department of Education. And the Department of Education and the governor is fully supportive of the Title IX guidance that came down from the Obama Department of Education federally about transgender individuals. Is that basically transgender individuals in schools are treated as the gender for which they identify with. So if you have a transgender young girl, then she wears girls' clothes, she uses girls' restrooms, she uses girls' locker rooms, she does girls' sports, and etc. And for a transgender male, the same. That case is going before the Supreme Court because a number of different states challenged those guidelines. The one thing you have to remember is that we live in a Commonwealth, and so each school board has control over their own school. And so the Pennsylvania Department of Education does not, we have worked with the School Board Association, et cetera, but we don't have the authority to tell every school what to do. So we can give guidance and advice, but to be honest with you, the school boards are frozen until that case comes down. And right now, of course, we have a 4-4 deadlock in the Supreme Court, so we'll see. We'll find out. So that case will be very important. And the school boards, they also don't want to be sued, so that at the moment they're kind of frozen by that case. But we have been working on that, yes.
Thank you.
Thank you. Yes?
Hello, I'm Quinn Ebegood. I don't actually go here. I go to Lafayette.
Oh, you out of here.
I'm about to
That's
head
okay.
back to school.
I've heard that's a good school.
So, as a non-binary person, I'm wondering what initiatives the Wolf administration is putting forward to, or like what's being done to further the understanding of non-binary genders in medicine.
So, yeah, go ahead.
And does it not make more sense to view this as a larger, or my own understanding of this as a non-binary person who experiences dysphoria but is otherwise perfectly fine with their own body, is that it's the larger social understanding of gender and gender roles within our society that's the issue rather than on a case-to-case basis.
So we are, we do have the voice of non-binary individuals on the work group through our stakeholders and community, and so we do discuss those issues. At the moment, we're really just trying to make some advances in terms of sexual orientation and gender identity in general, so it's going to be a stepwise process. I think that both are true, is that both the issues in terms of gender are impacted by the larger societal issues of gender and gender roles, etc. However, I don't think that takes away individual person's experience, who from their experience, whether they're 60 or whether they're 6 or they're 14, that some people do want to transition to the other gender. That it's not just sociological. That's how they feel inside. They feel female, even though they were male identified at birth. They don't feel non-binary, they feel female. So I think it's both societal as well as individual, and I think you have to take both into consideration. Thank you.
I rise to say that we've reached the end of our question and answer period, but I want to remind you that conversations can continue at the reception in Drucker Common, the Life Science and Philosophy Building. Let's thank Dr. Levine for a fascinating and important lecture.